What's up, everybody? This is Dr. Nick with Leverage Media. Welcome to another episode of Path to a Million podcast. I'm here with one of, he doesn't know it, but one of my early mentors. When I first came to Parker, I think you were one of the first speakers that I saw back when I really started out in practice.
Wow.
And I just thought it all made so much sense. You were so smart about how you represented it, and I think a lot of chiropractors have learned a lot of what they talk to their patients about nutrition through you. So for those that do not know the man, the myth, the legend, Dr. David Seaman.
Thanks for having me.
I appreciate you being on. Give the audience a little bit of background on who you are, what you've been doing in the chiropractic profession.
Well, for me, I graduated from Chiro school in 86,
Yeah.
1986.
Got it, perfect.
And from the very start, I was curious about why it was that certain patients didn't respond to the treatments. And back then it was mostly adjustments.
Right.
Rehab was not much of a thing in the practice. It was mostly electrical modalities, ultrasound and TENS and EMS.
Yep.
And that was pretty much the treatment, unless you did AK. And so or SOT. And so I was always curious, like, why do these people not respond?
Mm-hmm.
And so I started looking at it more and more, and then eventually, after I graduated, I came upon the fact that the pain system gets activated by chemicals that are produced if you have a lousy diet.
Right.
So I'm like, wow, you can actually induce inflammation and pain with diet. Now that was 1987.
And back then, that was, I mean, everyone knows that now. Like, it's like everyone talks about that, or
Right.
most people know about
Right.
that. Back then, I would just imagine that was a much more unique idea.
They were like, you serious?
Right.
You must not be able to adjust. That's why you're into this.
Right.
And I was taught, because anyone who graduated in the 80s, we were taught by guys who were like, I mean, they had no fear.
Right.
So I was taught in that era, and that wasn't my problem.
Sure.
My problem was patients who I was seeing when I first got into practice who were not responding. I'm like, so these must be, so now I started practice early 87 after graduating, and then
Where'd you
New York Chiropractic College.
New York Chiropractic?
Yeah, so my education it didn't push me into any ideology.
Got it.
You had like the pure back pain guys, and then you had the subluxation guys.
Yeah.
And they got along, and students didn't have the war that goes on the way you see now with the
Yeah.
straights, the mixers. I mean, it's just heightened for no particular reason.
Sure.
So I was fortunate to go through school in that respect, and then what turned me down this direction
Where'd
was
you practice at?
New York City.
New York City. Like
Yeah.
in Manhattan?
Yeah.
Nice.
Yeah. For like 3 years, and then I just realized that I kind of didn't really know. I needed to learn more about the non-responders.
Got it.
So I was able to, because I didn't.
So you're getting results, but you were more focused on the ones.
Well,
that
the
are
ones
just
who
like,
weren't, yeah.
right, which
'Cause-
makes sense.
'cause-
That's the ones you think about, like to keep you up at night.
Right.
Yeah.
And back then, and even today, it feels like, well, I must need a new soft tissue procedure.
Right.
Well, for the most part, if you don't respond to like 𝗵𝗲, which is just digital pressure, that was what we all learned soft tissue back then.
Yeah.
If that didn't work, odds of being scraped or taped or anything else, probably not.
Sure.
I mean, if you get zero response from digital pressure, are you going to get a whole lot more response if you do digital pressure and then lengthen the muscle? Well, you might, but if you're a full-on flamer, you won't.
Right. That's
So
what you call them, full-on flamers.
Flamers, yeah, because the flame is on.
That's right.
So I remember a handful of patients. You could hardly touch them. They were so tender.
Yeah.
And these were like young, thin people.
Yeah.
And I was like, "What are you eating?" I mean, once I realized this,
Yeah.
and I learned about it in a post-grad class after I was in practice for about 10 months or so, and he was a British neuroscientist, and so it was my first class about pain and mechanoreception effects of manipulation,
Yeah.
where I didn't take this neurology course and have to worry about an exam. When you relearn stuff without an exam,
Right.
your mind is set free.
Right.
When you're in school, your mind is not free.
That's true.
And you're endlessly worried about
The next test.
paper chase,
Yeah.
the next test.
Yeah.
And basically you can go through Chiro school, med school, PT school, and actually become less efficient with your brain
Right.
than you were before you entered, because it's just a memorization fest without much clinical context. And the first year and a half is basically basic sciences, and you leave basic sciences, which are often taught to us
Yeah.
by people who speak English as a second or third language, and they have an accent that can be really harsh, and then they're teaching you neurology and biochemistry, which is like another language,
Right.
and now you're toast.
Right.
So you get, you hope you pass, right? The
Yeah.
curve is low, you
Yeah.
pass it, you get through national boards, and you're done.
It's got to be in that top 80%, right?
And you're done.
Right.
And so then you go into practice, and now, hey, how come half my people aren't responding the way I want them to?
Yeah.
And then you start scrambling. But then there's no chemistry background to help you figure out why, because we've all been told that the spinal problems are either going to be subluxation, bone out of place fixation, mechanical back pain, and then now the biopsychosocial model, and none of it involves chemistry.
Right. Which seems like an important part.
Seems like an important part.
Yeah.
Yeah. So what I was shown in that October of '87, he shows the pain pathway, and he showed all the different chemicals that activate the nociceptors. And I'm like, man, I mean, I recognize them all from basic psi, but half of them I knew were diet related. So I went back that night to my office, and I went through all my books, and I'm like, oh my God, this really is diet related.
Yeah.
So I brought it back. It was taught by Dr. Barry Wyke, W-Y-K-E, famous British neuroscientist who was a great friend of chiropractors and manipulation physiotherapist. He ran the neurologic clinic at the Royal Academy of Surgeons in London. I'm pretty sure that's the name of it. And his whole focus was joint neurology. And he came to NYCC 3 times, and the one time that I went was after I graduated, and that was for a full 12 hours. So he showed the chemistry. I went back, and I brought one of my books back, and I said, you showed the prostaglandins, the PGE2, that activate the nociceptors to cause pain. If you eat omega-3s and less omega-6s, this book, which was a standard medical nutrition book, you'll have less inflammation. And I go, you think that you can influence diet or influence pain with diet? And he was sipping a Coke at that point.
Right.
And he's like 75, too.
Sure.
And he's a Brit. And Brits don't eat a lot of vegetables.
Right.
So he said, interesting. He goes, I don't know. I'm like, okay, that was important when you're 27.
Yeah.
You don't need a massive negative thing. But I'm stubborn enough where I would have stuck with it anyway because it was very clear.
Yeah.
Excess omega-6, PGE2, pain, inflammation. Reduce the omega-6, increase the omega-3, PGE through, anti-inflammatory, no nociceptor activations. I'm like, okay. So from that point on, I had like maybe 3 articles. I collected 10,000 photocopied paper articles and filled 10 filing cabinets, 4 drawers high, like 2.5 feet deep.
Wow.
So I relearned everything.
Yeah.
And I'm like, man, I think we should know this stuff.
Right.
So I started talking about it, and I got endless arguments from all the professionals. Like, what are you saying, that adjustment's not important? Like, no. I'm saying if the adjustment is not working, or if they can't do exercises, the flame is on.
Right.
But the flame is difficult to understand as a DC who hasn't thought about it since National Boards Part 1.
Right. So so that was '87 when you go and you meet Dr. Wyke. You're still in practice for a couple of years after that.
Yep.
Do you start implementing that?
Oh, yeah.
With
Immediately.
every patient, or just the non-responders?
Well, it would depend who they were when they came in, because I kind of was able to tell. If you palpate someone lightly and it hurts, orthopedic test means you push.
Right.
Okay, just palpation, you can do graded palpation.
Yeah.
And you should be able to press in there decently without causing pain.
Right.
So that would be my threshold.
Got it.
And
so anybody that had some level of pain with just light pressure, you're like, okay, I'm going to give this a shot.
Well, I would first do my chiropractic work.
Yep.
If that didn't work, then I dropped the bomb that they got to turn the flame off.
Got it.
And the main thing back then was just, we should just eat minimal sugar and flour and refined oils, eat whole foods.
Yeah.
Yeah.
I mean, I literally, I remember when I first started, after I saw you, you had some very basic article, like a 3-page article. And I mean, I photocopied it 200 times, and I was just giving it out to anyone that even looked remotely like they might need to change their diet. And it really was amazing just with those, because 90% of them didn't follow through with it. But with the ones that did, it was just the changes were so much better. They were so much they were so appreciative, because I was focusing on more than just bone out of place, and because most of them have been to chiropractors, they've tried fixing it, it comes back the same way, sometimes worse. And but when you deflame that diet, it's weird how that works.
Yeah, it's not weird. It's really is. It's real.
Yeah,
it's really real.
Yeah.
And so you said that if people followed through. You don't have to follow through to be perfectly deflamed, if you want to use that language. The average person, if they just reduce their intake of sugar and flour and refined oils and uptick some vegetation, for the average patient seeing a DC, that typically is enough, unless they're full-on flame, like obese, smokers, pre-diabetic, metabolic syndrome, or diabetes. Those people need a little bit more, but the recommendation doesn't need to change just because they have a worse condition. They just got to be better at getting rid of their sugar, flour, and refined oils.
Got it.
So for me, it was always, if you don't respond, well, then you should think about this. But the problem is difficult if one's practice ideology is bone out of place, mechanical back pain, biopsychosocial, because none of that stuff involves food.
Right. But I guess I'm confused when people think that like their thing can be the only thing that could be the problem. You know, even if if you think that that's the way that you should be focusing on spinal issues, the spine, is inside of the rest of your body.
Yeah, it's part of the chemistry.
Yeah.
And that's the thing that people also, if you think about it, you look at joint cartilage. I'm talking in a living human, not dead. Joint cartilage is like 70% or more water. Right?
Yeah.
So our mechanical tissues, our structural tissues are mostly water.
Right.
Muscles, like 60% water. Nucleus pulposus, 70, 80% water.
Yeah.
So we're basically using our body, it's kind of like Dune, right? The water. Do you ever see Dune, the movie?
No.
It's all about preserving water on this thing, so it's all about the water.
Got it.
So basically our body is mostly water, so we're sacks of water that move. And if our sack of water is too flamed up, when we move other people, they're not going to respond the way we would like them to.
Right.
So my approach here is, if you find these people, you want to focus on simple recommendations, because if I'm in practice now, I don't want to spend time talking to people about food.
Right.
Because, I mean, as a chiropractor, I think, well, I'm going to do manual care, just to cover all of it, soft tissue, immobilization, manipulation, and rehabilitation and postural stuff. Those patients who respond there, they're great patients. Right? So my recommendation then, I got a non-responder, and that's why I wrote these books, so that, particularly this new one, because the word rotting.
Well,
right?
And I want to talk about that specifically, because I just love that languaging, and I think that's such a great way for patients to understand it. But I just want to kind of put a bookend on your story. So you stayed in practice a couple years longer. Did you just decide that you're like, this is my passion, this is the way I want to go on the nutrition side, and you got out of it, or?
See, for me, it was never really the nutrition side. It was mostly the chronic inflammation side. Yeah. Because then, at some point, as I got to see, people think, not everybody think, oh, he's a nutrition guy. Yeah. I'm really the the deflame guy. Yeah. Right. So my closing talk here on Saturday night is going to be how sleep, stress, and sedentary living creates inflammation. Yeah. And there's well-known pathways as to how they do. Right. So I'm really more about turning off the flame. So let's just say you got a healthy person who's not responding. Yeah. Well, maybe they had a death in the family. Anything that could be stressful that they're obsessing over, as 𝗵𝗵𝗿𝗀 said, auto-suggestion. That will flame them by the thoughts that they're dwelling on. Got it. And then if they're not sleeping, that adds another layer of flame. And when you're stressing and not sleeping, does the average person exercise more or less? Less. Yep. So now they're losing anti-inflammatory exercise. They're pro-inflammatory, stressing, and non-sleeping. Yeah. They could be eating the most perfect organic, vegan, omnivore diet and still be a non-responder because of those three. Got it. So my first introduction was food and inflammation, but then as the research emerged into the mid-late 90s, stress was now, people think cortisol, but stress is associated with a massive elevation of pro-inflammatory cytokines. So then all of a sudden I just took my nutrition thinking, and then I just applied the same chemistry, because it's the same chemistry. Yeah. So if you know how a pro-inflammatory diet creates inflammation, you then now know, with a couple of different chemicals in there, how lack of sleep, stressing, and sedentary living creates inflammation. Right. And then you have these 4 lifestyle factors that you can focus in on if a patient doesn't respond.
Which is great because it's like now you've got different tools.
You have options
instead of just being like, well, I tried that thing.
I tried that, or I'll keep adjusting, and maybe the fixation will clear,
right?
Or maybe the subluxation will go away, or maybe a nape will show up, or something like that, right? So it's much better to say, well, who's the patient that I'm treating?
Yeah. So what was it that? What did you do after you left practice? So you got out of the practice in New York City. What did you do then?
Well, I had some consulting work. I was able to get some income through like non-practice means, basically, just easier, just to mostly consulting and some nutritional stuff because I was into
like
nutrition.
Consulting chiropractors.
Well, nutrition companies too.
Oh, okay, got it.
Yeah. So, and I also wasn't married, no kids, so I was able to be broke.
Right.
Without having an exceptional overhead.
Yeah. That's when I was growing my practice. That was my secret power was that I just had to feed myself and like pay for my cell phone. That was about it.
So I was lucky that I was single and I was and I didn't have except for student loans. I mean that was pretty much it.
Yeah.
So I lived lean.
Got it.
And I just relearned stuff.
Yeah.
And I did that for like 2 years, and then I started doing postgrad just kind of worked out that I did, and then I figured I'd get back into practice because I developed patient education tools back then that were based upon science and mechanoreception, nociception, and inflammation.
Yeah.
And so I figured, well, I'll get back, and then people started liking those, and I started doing postgrad stuff, and I never got back into practice.
Fair enough.
Except for a couple times here and there, like a little bit in the schools and some part-time stuff.
Yeah.
Yeah.
And so you said that you've got 10 books in you. Or that you want to hit 10 books.
Right. I got 4.
This is number 4.
Actually, number 5, but this is number 4 for patients.
Got it. What was the 5th one?
So it was called Clinical Nutrition for Pain, Inflammation, and Tissue Healing. That was 1998.
Okay.
And I had another book that was, the pre to that book was part of a slideshow and a video in 1995. So since 1995, I've had something that the DCs have been using. And then the book, I made an official kind of textbook. A couple of schools used it as part of their curriculum.
Nice.
But then, I wasn't sure if I had enough game to create layman's books, and I finally did it in 2016.
Got it.
So
you've done 4 since then.
So 2016 was the Deflame Diet, the original. Deflame your diet, body, and mind.
Got it.
And then I didn't put weight loss in there because then people think, well, this is just for weight loss, which is not how it goes.
Right. Because skinny people have it too.
Yeah. Exactly. Skinny people can be flamed. If you just eat Twinkies and drink corn oil, but you stay your same body weight, you're flaming anyway. Right? So then I came up with... I'm
thinking of someone drinking corn oil.
Well, yeah. Well, French fries is basically drinking corn oil.
Right.
You take a bite and it oozes.
That's true.
And even more would be
only good French fries. Yeah.
Well, the bloomin' onions, for example, those are really just dripping.
They literally will quench your thirst.
Right. Yeah. They're dripping with oil.
That's right.
Yeah. So then I wrote a book called Weight Loss Secrets You Need to Know.
Okay.
So that one is big. It's the mental game for controlling your caloric intake.
Okay.
Because everybody has an eating beast on the inside.
Right.
And the best way to control the eating beast is to force yourself into a time-restricted feeding mode.
Just like with animals.
Basically, I don't know how they roll, but I just know that the average person right now, they have a snack at 10 o'clock, and they're eating breakfast at 6.
Yeah.
They never give their system a fasting state, which is very anti-inflammatory. So the first thing to go for is to go beyond, work up to going beyond 12 hours. If you eat every 3 hours, wake up at night and have a snack.
Yeah.
So the goal would be to go between at least 13 to 16 hours for the average person of no food, and then eat your calories in a time compressed window.
It makes sense.
And what that does is it forces you to engage all the eating beasts within issues. You're like, I'm hungry, I want to eat. It's like, eat. And it's just, it does this to you, right? So you say, wow, look at this. This is like a primordial drive,
right? Because
historically, humans had to work pretty hard for food. We couldn't just walk down to the cafe and score 6 donuts and a cup of coffee, right?
Right.
We had to go hunt and work for our food.
Yeah.
Okay, so that's gone.
Yeah.
Right. So our primordial drive to eat can be satisfied anytime we want.
Right.
So we have that issue. Then we get a taste for high-calorie foods like sugar, flour, refined oils, and salty stuff that's cooked the same way. We want that. We got a hankering for it, right? And who gives us those foods the first time? People who love us the most, our parents and grandparents, right? And then parents and grandparents do it today.
Yeah.
And so the kids I want ice cream. Why? They shouldn't even know ice cream until they're 10 or 15. Because it's of no use to have that desire in your body.
Yes. I am glad that you said that because I don't have children. But if I did, I just see like other chiropractors like on Facebook and whatnot that their kids like have like radishes for snacks and stuff. And I'm like, yeah, like until they're like 7, they don't know anything unless you tell them.
No idea.
They don't know what McDonald's is.
Right.
Like the only way that they know that it tastes like that is because you took them there.
Some adult basically introduces them to what I call dietary crack.
Yeah.
And then you're a crackhead from the time.
Now I feel smart that someone as smart as you thinks that.
I'm not that smart. I just know a lot. It's different.
Right.
Yeah. I've been in it for so long, it creates the illusion of intelligence.
I got it. All right.
So then I did the breast cancer book, because that just like...
That was the last one before this one, right?
That was the third.
Yep.
And I was going to do a female health book, but the breast cancer chapter was going to be so long, I just decided to do a full book, 100 some odd pages about breast cancer, because that's a huge issue. A lot of DC patients, a lot of largely female DCs do a lot of family health stuff, women's health, and they ought to know the pathways that from diet to breast cancer expression.
Right.
And it works for prostate cancer too.
Right.
And then this book about biological rotting, which just came out in June.
So I love the Deflame Diet to stop your joints, muscles, and bones from rotting. And this is written for the general public.
Absolutely.
And you were telling me like how you came up with rotting. Because I love that, because I think people like understand it more. I was reading like a post that you did on Facebook a while ago where you were talking about like arthritis, osteoarthritis, and like how that's basically like your joints rotting.
Yes.
And I'm like, that was such a good, it's just such a good visual in your head when you hear that or you read that. And it's what you're trying to get across, and nobody wants to rot from the inside.
Right.
So
rotting works better than chronic inflammation. Inflammation is out there so much that like, I just have to take CBD oil or like special curcumin that was blessed in some mountain range in India, right? Well, let's just say that like, so this is the threshold where the flame can go up. And so if you exceed the flame this much, you could take CBD or curcumin or whatever, vitamin D, you may just get down to here and have zero clinical effect, and then have the perception that this...
Because it needs to get below the threshold.
It's got to get below the threshold.
Right.
And the biggest... Now, if you're here, just because you're stressed out and worried and not sleeping, and you take some curcumin and you're down to here, well, it's magical then. Yeah. Right? But the problem, though, is for people who are chronic.
Got it.
And so an example would be this. What really hit me, and I had to spend some time for this new book for the joint chapter, is that only about 10% of all people who have osteoarthritis have trauma-induced OA. Now you think about our education and PT education, it's all trauma or wear and tear. Now wear and tear is made up. Wear and tear is language that refers to trauma that's cumulative, which is a conjuring. So the way traumatic OA is defined properly in the rheumatological literature is, so I was a high jumper, and so when you're running up to the bar and you blast your knee down, if I did that enough, and I did enough of the jumping and bounding exercises, I could have damaged my articular cartilage, and I would have had pain. That would be called traumatic OA. Right. It's supposed to heal within 3 months. Now when it doesn't heal and it goes beyond 6 months, the rheumatological literature says that's because there was too much flame there and you didn't turn it off. Got it. So even chronic post-traumatic OA is inflammatory. So it turns out that at most 12% of all cases of OA are traumatic. Got it.
Which means the other 88% are rot.
Well, maybe a little bit less, because you can have slip femoral capital epiphysis, and that can lead to OA of the hip.
Fair enough.
But I mean, when you're in practice, how many people who had slipped epiphysis?
Not a lot.
Not a lot.
Not a lot. Yeah.
So let's just be really generous and say that traumatic OA and the other causes of OA, infections and things, maybe 15% of all cases. Yeah. What's the other? 85% occurs as people age. Got it. And aging is called by scientists inflammaging. And so if you look at people over 60, where it becomes most obvious that you have osteoarthritis, when you're over 60, about 40% or more of people over 60 have the metabolic syndrome, which is a chronic pro-inflammatory state. Right. And half of the people who are in their 60s who have metabolic syndrome have osteoarthritis that emerged with the metabolic syndrome. Right. Now that cannot be fixed by glucosamine. Right. And that is why people who say, well, you got some guy who's 65, give him glucosamine and it'll fix it. No, it won't, probably.
Yeah. Same way with the
same,
it's like if they're at the edge, like maybe it'll help.
Right.
But if they're way up here, it's not going to work.
They're not going to help. Yeah.
So I always like to give like really actionable things that the doctors listening can do. So if they want to add in deflaming into their practice and they want to try to help people with their nutrition and try to give them tips on sleeping better, we were talking before this that simplicity, because I was explaining to you the structure of the show, like 0 to 250 up to 1 million, and you're like, the answer is pretty much the same regardless of what stage you're at. It's really about simplicity, and so that you don't become like their nutritionist. Like, you just want to give them some things that they can do on their own. So what would you give, like, regardless of what stage they're at, what would you say is the best way to implement this stuff in your practice and educate people?
So when it comes to exercise, you got to do it in a graded fashion based upon preference.
Yeah.
When it comes to stress and lack of sleep, that's really not like my domain. You got to address whatever ones they are, and there are lots of different books out there and experts on that. When it comes to dietary stuff, the first thing is to cut calories so here's the best way to look at it. If you look at men and women mature before men. And that makes a lot of sense, because before we had running water, people were dying pretty young. You want to be able to get pregnant when you're 16,
sure,
right? Because you may only live to 40.
Yeah.
People say, well, we're living so much longer now. Why, blah, blah, blah. I go, well, yeah, because you weren't living outside.
Right.
Let's take most of these Americans who say, oh, yeah, we're living longer now. Out to the woods you go for a year, you'll be dead in 2 months. Right? Because it's hard to live off the land.
Yes.
So the way to look at this is women pretty much reach their proper adult body weight between 16 and 18 or 20.
Okay.
Guys get there between 18 and 25. So unless you're a big guy, we use guys as an example, most guys, when they were 18 to 25, they had a waistline 33 or less.
Mm-hmm.
So that's where you want to be.
Yeah.
That should be the goal, to reduce your body fat. Now, you don't have to reduce it. So let's say this is the threshold.
Yeah.
And then, so this would be the level of flame if you're a 32. You're a 40 right now. Here's the level of flame at a 38. Now you got a patient who will respond to your adjustments and therapies if they get below that threshold. Because people who are below the chronic flame threshold can still have pain.
You're right.
It's just not due to lifestyle.
Right.
It's due to whatever whatever problem with their joints, muscles that they have.
Yeah.
You treat them, boom, they're back down.
Yeah.
So caloric restriction is the first thing to consider.
Mm-hmm.
Time restricted feeding, move into that next thing, because you can actually eat some of the same crappy foods, but if you compress it and the calories are appropriate, you can turn the flame off eating donuts.
Yeah.
Not a ton of them.
Right. What do you do? Like, what's your time frame of eating?
For me personally?
Yeah.
So I haven't eaten yet today. It's after 12 noon, and we're on the West Coast, so I'm an East Coast guy, so it's technically 3 o'clock for me.
Yeah.
I think I finished dinner last night 7:30 maybe.
So that's 17 hours? Like, what's a normal day? Is it like 16 to 18 hours?
I go for 16.
Yeah.
But sometimes I fail.
Yeah.
But I don't fail ever less than 13.
Got it.
The reason why I picked 13 is not arbitrary. Is because when I wrote the breast cancer book, I was looking at fasting for breast cancer, and it turned out that women who had breast cancer, so you had, say, 100 women with breast cancer, and 50 fasted 13 hours or more a night, versus the other, those who went 13 hours or more had less recurrence of breast cancer.
Wow.
Just by compressing their eating window a little bit.
Wow.
Yeah. So that's why 13 at least, and then go longer.
Got it.
Yeah.
So caloric restriction.
Time-restricted feeding.
Time-restricted feeding.
Yeah, getting rid of sugar, flour, and refined oils, increasing vegetation, and then just 3 basic supplements to start off: magnesium, fish oil, vitamin D.
Got it. And so...
No, wait. How easy is that?
That's easy.
It's almost so easy. It's like, well, I've had people say, that's too easy.
There's got to be more to it than
really?
that.
You need to do more. Okay, so this is what always... It's just a simple adjustment. Well, how come that can be simple, and what I just said is too simple?
Right. what would be the best way for, like, do you consult with any doctors on like how to implement that in your practice, or how to have that conversation with the patients? Do you think it's a good idea to like package it as one thing, or is it just like a conversation that you should be having with every patient?
Okay, so it depends upon how you want to roll in practice.
All right.
My approach is not one of those packages you have to buy into, it costs all this money to do it.
Yeah.
I'm really much more, pretty much everybody knows that vegetables, good.
Good, right?
Fish, good.
Yeah.
Unless you're a radicalized vegan who thinks anything that has eyes is bad.
Right.
But they're a separate population of people.
Sure.
And then we know that sugar, flour, and refined oil is bad.
Yeah.
Everybody knows that.
Yeah.
Why complicate it? Now I wrote the books to answer the questions that patients would have. So if I was in practice, I would have to be forced into doing consultations with patients, and I would charge a lot, because an hour of time, how much is an hour of time worth in $1 million practice?
Yeah.
A lot of money.
Yeah.
Right? So most people really, I don't think, should be spending all this time, because it's not that complicated.
Yeah.
They have medicalized and complicated eating vegetables. That bothers me.
Yeah.
So my recommendation would be to a DC who just wants to just get people below the flame threshold.
Yeah.
Unless you want to have a practice that's pure nutrition, here are all your protocols, that's not me.
Yeah.
I've got a Facebook page where I post stuff, a YouTube channel where I post stuff, and these really reasonably priced books that I have that I do volume discounts for DCs or anybody else on my website. And so someone who's interested, that's why the rot book is good.
Yeah.
Right? So you have someone who comes in and they don't respond. Right? If you have if you have these books sitting in the waiting room, right? Like, here's this, you say, Doc, do you think I'm rotting?
Right.
So that's the question that you want.
It's better than having People magazine.
Absolutely.
Yeah.
So you say, so somebody may say, well, patient will say, well, do you think I'm rotting? You say, well, most of us are to some degree. Mm-hmm. And then you just do this. This is the rot threshold. If I treat you and you don't respond the way we want, you probably got to reduce the rot a little bit.
Right.
How easy is that?
Maybe the rot rate.
Yeah, yeah. So there's a rot rate, and so they should, if they can read this in the waiting room, and if they want, then they can buy it online or in an office, and then the book answers those questions. Now it's easier for the DC if the DC and these are not big, complicated books.
Yeah.
They're for
and
laymen.
they're written for laymen. Yeah.
Yeah, but I mean, they're written for laymen who have at least a high school education and who have an interest.
Got it.
Right, so that's one thing too for patients, for DCs in practice. Well, no one cares.
Yeah.
Well, that's ridiculous. How could there be this intense vegan movement, the keto movement, right?
Yeah.
How could there be no interest?
Right. There's always interest.
There's always interest. It's just you got to you don't go say, well, you got a truck driver who doesn't sleep. He's paying massive alimony. He's got a miserable life. He's got 3 ex-wives and 6 kids, broke like crazy, smokes and just eats in trucks.
Yeah.
That guy probably won't change a whole lot.
Right, right.
So you want a motivated person.
Mm-hmm.
And I would say in my experience, depending upon how you use your language, you can get people interested if they know that they might be rotting.
All right, so let's say that. Like, how would you, let's say it's a simple conversation. It's, you've got the book there as a tool. You have these like 5-6 principles that you give to people. What would be the way that you would start that conversation? Somebody's not really responding. They haven't asked about anything. And how do you broach that topic with them?
There is no one answer for that topic. It's based upon who the patient is.
All right.
So let's just say a patient thinks that they're awesome.
Okay.
Right? They're obese chain smokers who think they're awesome.
That's probably a good avatar, yeah.
That person, you probably wouldn't really necessarily open the conversation.
Right.
But here's how you could say it. And this would be the easiest way. First of all, you have to be unafraid to take out a tape measure and do waist-hip ratio. So here's another way you can look at if someone's flaming. If someone has elevated waist-hip ratio, elevated waistline, which would be basically the same thing, sort of, and then elevated blood pressure, and their body mass index is up. Those 4 markers, if they're all elevated, it's very unlikely that they would not have hyperglycemia, hypertriglyceridemia, low HDL, probably low vitamin D.
Yeah.
So you can use those simple markers, stuff that we should be doing in our office anyway.
Would you recommend doing that as like in the first exam?
Absolutely.
And having that conversation as part of like the day 2?
Well, if they ask, because whenever you take out a tape measure, you got to be comfortable measuring people who have if they're really sensitive, sir, you might have too much human tissue of a non-muscular origin.
Right.
Yeah. So, but you don't have to do. You just do you do body weight.
Yeah.
Waist hip ratio, BMI.
Yeah.
Waist circumference, blood pressure.
Got it.
If they're elevated, the patient is likely to say, "You think that's a problem? I won't know until I start treating you."
Yeah.
So you see, that's the way you plan the conversation in the future.
Yeah.
You treat them, because anyone in practice who's actually observant of their patients, you know darn well that if a patient comes in and say they got a 6 out of 10 on the pain scale, and you adjust them on Monday, after the adjustment, they're 6 out of 10. They go home, 6 out of 10. They wake up, 6 out of 10. All Tuesday, they're 6 out of 10. They wake up in the morning on Wednesday, 6 out of 10.
Mm-hmm.
They come to your office at 1 o'clock, 6 out of 10.
Yeah.
You adjust them, 6 out of 10. And that goes on for that entire week where nothing changes.
Yeah.
What are the odds that the fourth adjustment will make them go from a 6 to a 3?
Not great.
Almost non-existent.
Right.
So, if that's the case, so remember we did the waist-hip ratio and you asked about that? We probably got to work on this a little bit.
Yeah.
How much? Just to get you into the normal range.
Yeah.
So we're going to lower you to, like, as opposed to if you got a 42-inch waist as a guy or a 38 as a girl, we want to get you below 40. And maybe below 40 you'll become a responder.
Yeah.
And now they got a goal, a simple goal.
Right.
Yeah.
That's good.
Yeah.
We use the wellness score with Chiropractic, because my office is an 8 weeks to wellness office. So we, like, a lot of these people come in, like expecting to have that conversation.
That's even better.
And it's great, because when you get a chance to talk to people about that right away, they know that that's part of, like, what we do here in the practice. Like, we have a gym in the office.
So this book in the waiting room we'll start that conversation without even having to worry about it.
I love that.
Yeah.
In terms of being able to have a nutritional program in the practice, is there anything beyond the simple stuff and the giving them the books that you would recommend? Are there any, like, supplements that, like, protocols or?
Yeah. So protocols to me are problematic.
Yeah.
And what I mean by protocols for named condition.
Yeah.
So there's this pathway that, remember in school for national boards we had to memorize all the vitamins?
Yes.
So remember, like, do you remember the amino acid that's the precursor to niacin?
No.
It's no big deal. It's tryptophan.
Okay.
You memorized it and you knew it when you were in school. Now, very few people in America are deficient in niacin, and the tryptophan pathway is working. But that pathway gets turned on by inflammation. Mm-hmm. It's called the kynurenine pathway, which can make your eyes roll back in your head now because you're bringing yourself back to biochem class in third try or second try, and it sucked. Mm-hmm. Like, oh my God. So this kynurenine pathway becomes activated whenever you're flaming.
Got it.
And so if you know that pathway is overactive in traumatic brain injury patients, PTSD patients, depressed patients, autistic patients, and basically every other chronic inflammatory condition. So my suggestion is to focus on basic chemistry, without necessarily know the whole thing, but know that what you're doing is targeting these pro-inflammatory pathways. Right. And then you can avoid protocols for named conditions. So what you could do, no matter what the case is, and assuming there's no drug interactions, would be like a multivitamin, magnesium, fish oil, vitamin D, probiotic, iodine, and then glucosamines. Like, those 7 things could basically be in any office, and that could be all that you live on.
Got it.
You can reverse diabetes with that without getting into all diabetic protocols, because it is a diabetic protocol. Right. But diabetes is a chronic pro-inflammatory state, and that if you know that, you can set yourself free from all the protocol-y stuff that people like to throw in there. Oh, will this help that? Well, if they're flaming here and it's here, it will do nothing. Yeah. So you want to know what the flame level is.
Got it. Is there a good way to judge where the flame level is?
Yeah, there's lots of markers. So if you want to just get a free paper that I wrote, it was published. It was actually, oddly enough, I've written 4 scientific papers on pain, diet-induced pain and inflammation, weight loss, and then the body mass index stuff. They've been cited by, shockingly, Harvard scientists 3 times cited 2 of my papers.
That's great.
And the other 4, if you combine them, you're hard-pressed to find a continent where a scientist hasn't cited it. And in most continents, multiple scientists.
Great.
Right. So the paper that they can do, if all you do, get this one, this is kind of cool. Yeah. If all you do is put into your search window, most people do Google, right? So you Google BMI space pain. The first paper that appears is my paper. You click on that, and you download it, and you print it out, and I've got a chart of markers to track.
Perfect.
And my book has more of them.
That's great. So they can order these for their office and also for their patients on Amazon, or is it best to go through your website?
Well, it depends what they want to do.
Yeah.
If you don't want to hold anything in your office, which some people don't want to have stuff and they want to sell anything, so then you just tell patients to just go to deflame.com, click on the buy book, and they get sent to Amazon for just one book.
Got it.
If you want volumes, you get them from deflame.com.
And that way you can just hand them out.
Yeah, there are some DCs who buy volume just to give to patients because they'd rather spend $9 to give a patient this to read rather than spending all the time talking, because it's very difficult to build $1 million practice if you're yakking about donuts with people.
Right, things that are already in here. Right.
Yeah.
Well, also, it's like you can tell them to go do it, but if they walk out of the office, life happens, and unless they do it right then, they're probably not going to. Yeah. When you're able to hand something to them, and especially if this is on your side, this is talking about the chiropractic lifestyle, and it's going to allow you to get better results if they are deflamed.
Absolutely.
So to be able to hand this to somebody for $9 is,
well,
in my opinion.
if you just want to give it to them,
that's what I'm saying. Just be able to hey, what we were talking about with the waist-hip ratio, and here's the solution. Learn all of this, and then let's talk about what we can do.
Right. Exactly.
And have you ever had anybody that did like a book club or took people through it as a group? I feel like people would like doing that, with the accountability and all that.
It was really interesting. One guy contacted me just recently. He did a talk and talked about it. And he goes, there was some interest. He ordered 50 books, and he just uses them as his lecture tool.
Yeah. Have you ever put together a lecture that somebody could do? If they wanted to promote this book, they could go out, and because I think that's a good idea. It
is a good idea. But part of the problem though is if you give, this is where people actually need to uptick their learning a little bit, because if you just give people a lecture to read, odds are a patient will ask you a question, and you ought to know the answer.
Sure.
And if you just read 10 slides, you probably won't know the answer.
We got to teach them all the answers too, but
now that's very difficult because it's so broad.
Yeah.
There is some level where the DC should learn this, because I'll give you an example. The chronic musculoskeletal conditions that are said to be trauma or mechanical are not.
Yeah.
And that would be osteoarthritis, except for the traumatic ones.
Mm-hmm.
Tendinopathy, not the tendinitis after injury or playing golf, tennis elbow. We're talking chronic stuff in the aging population. So it turns out that people who are full-on type 2 diabetics, they're much more likely to have atherosclerosis, because diabetes chemistry is atherosclerosis. Well, diabetes chemistry is tendinosis. So most people who are full-on type 2 diabetics have tendon pathology.
Gotcha.
And if they exercise, they're going to bring out their tendon pathology.
Yeah.
If you don't know that, then you're going to be scraping, taping, treating, and get no results. Why not?
Yeah.
So osteoarthritis, tendinosis, osteoporosis, disc herniation, muscle weakness and deconditioning as we age, depression, all the same chemistry.
Got it.
It's not hard to learn this.
Yeah.
And it's actually all of a sudden, so DC should, and then really what they should do, I know this is not for everybody, you can create your own 10 slides that are written based upon your language rather than mine.
Yeah.
Because my language is more sophisticated, just because I've been in it for 30 years, than someone who's hey, I should do this.
Yeah.
Because they'll be I don't understand, these words aren't my words.
Yeah.
You need to use your own words.
Yeah.
And if you do that, then you'll actually be the expert in your area. And that's what you should do.
That is
because then you could actually what if you get asked to do a hospital talk or to some nurses?
Yeah.
Do you want to just read my slides and not answer a question?
Probably wouldn't go over that well.
Wouldn't go over that well.
Yeah.
And if you do it on your own, then you will be perceived as the expert. And that will help you launch further up. Not to get people in to do nutrition, but so that you are the go-to chiro in your town for all the stuff that we do as chiros.
Makes sense. All right, so deflame.com is the best place to follow you.
Yep.
Facebook and YouTube as
Deflame
well.
Nutrition for Facebook, Deflame Nutrition for YouTube.
Got it. Perfect.
Yeah.
Well, Dr. Seaman, I really appreciate you being on. Like I said, I came to Parker maybe in my first year or two. Didn't know what the hell.
Was that?
What was that? I've been in practice 14 years now. It's my 14th year.
Wow.
And I remember watching you speak, and like I said, it just like had such an impact on me, and it probably led me down the path because I ended up doing a creating wellness center with CLA, and then I kind of graduated into 8 Weeks to Wellness. But I think it really like all started with I was searching for something beyond just being able to adjust people,
right.
Because I got tired of people coming back with all the same stuff over and over again, and also like they're fat and smoking, and it's like this adjustment is not fixing that,
right? Exactly.
And I think that like seeing you speak and seeing how simple you made it really made a lot of sense to me, and so I just appreciate the impact you had on my career and probably the tens of thousands that have.
Once you hit my
well.
age, like I'm 60 this year,
yeah.
So I got 10 to 30 left. No matter how you look at it, you never know, right? So I'm like, geez, that's good to hear. Thank you. Yeah.
Well, I would imagine that there's a lot more out there like me that you've impacted on thinking about things the right way instead of like running after the next fad.
Oh, good.
So
great.
Again, I appreciate you being on,
Thanks for having me on.
Good luck on all your speeches this weekend.
Appreciate
You
it.
speak like 9 times this weekend, I think.
Yeah, bunch. Yeah. Thanks.
All right, we'll see you on the next one.